Tracy Johnson, founder of A Ray of Hope, which is a fibromyalgia, chronic fatigue support and research organization. The co-founders are Joni Cantrell, my daughter, she's waving back there. Can't get away from the table of information. The other co-founder is my sister Paula Craig. There she is, back there. That's what I was waiting for. I wanted them up here so you could see them. You'll get to meet them later. We are all patients. I was going to tell you some of our experiences we've encountered the past couple of years in our research. However, my co-founders informed me I can't have more than 15 minutes. So I'll try to make this brief. Approximately 6 years ago, my symptoms began following a car accident. After many tests and physicians, I was told fibromyalgia, no treatment, no cure. I accepted this because I knew absolutely nothing about fibromyalgia, nor I didn't know anyone else that knew anything about fibromyalgia. A few years later, my sister experienced a trauma and an injury and began showing same symptoms. But unfortunately, she lost 90% of her colon before her diagnosis. 1 year later, my daughter had an injury, and she too began showing fibromyalgia symptoms. She lost her gallbladder and female organs before her diagnosis. They both have been to the point of needing wheelchair assistance and emergency care. We were panicking. We needed help. So we began researching. Our first good proof that fibromyalgia is much more than just muscle rheumatism was by a blind study that we stumbled upon that was done by Dr. Bennett of Portland, Oregon. This study proved that this definitely was not a psychiatric illness, but rather it affects many areas of the body. The title of that study is called Fibromyalgia and the Facts. In a Spokane hospital, we discovered an excellent book by Dr. Byron Hyde of Canada called The Clinical and Scientific Basis of Chronic Fatigue Syndrome, Myalgic Encephalomyelitis, which Dr. Goldstein has also written in the book. Then we heard about Seattle Fibromyalgia Association and that they were having a conference with a Dr. Gold somebody. We didn't know who that was or what it meant. Actually, it became a joke between us. Gold who? We didn't care. We just wanted to find out what he had to say. On July 11, 1993, we experienced our first ray of hope. Hundreds of people just like us. And the guest speaker was our one and only Dr. J. Goldstein. My sister, my daughter, and I kept signaling each other like, can you believe this? Can you believe it? It was very emotional because we thought we were the only three in the world that had this. Afterwards, I reluctantly approached Dr. Goldstein and softly said, would you consider coming to Montana? He hesitated and said, yes, I could do that. Have your hospital contact me. I backed up slowly, and I felt faint, and I was speechless, and then said, you will? And he just smiled. So I immediately grabbed my two cohorts and said, you're never going to believe this. So back to our room we went, got our medications, our heating pads, hopped in bed and started reading our information, and then we made all of our big plans all the way back to Missoula. In February of 1994, we sold tires so we could go back to Seattle to hear Dr. Goldstein again. We found other good researchers but we still felt and do feel that he is top. Even though our sponsors kept falling through, we never gave up hope or faith. In June of 1994, I approached yet another sponsor, once again, and dropped a line to Dr. Goldstein to let him know we were not giving up. On July 6th, early in the morning, I received a call from his wife, Gail, and she very nonchalantly said, "Judy, we apologize for such short notice, but Dr. Goldstein has decided to come and speak in Montana in August." Once again, I was speechless. Finally, I responded with, "Great." My wheels began turning 90 miles an hour. Nothing else mattered. Short time, no money, just go on blind faith. And that we did. And now here we are, and so we're thrilled to share this truly dedicated doctor with you. Now I have one other thing to add. So many people that I've talked to on the phone while I've been organizing this have asked me, "How do you do this?" Well, I'd like to take this time to show you my great support system. And I'd like to ask everyone in my family to please stand up and to motion so that they can see. Troy, Joni, even my brother-in-law, where is he? David?
Guess what? He left.
He left because he knew I was going to do that to him. Because the rest of my family all say to me, "Well, I'll do that for you, I'll do that." But when my sister asks him to do something, he'll say, "Oh, do I have to?" So anyway, now we are also very fortunate to have one of our own Missoula physicians that has taken a sincere interest in this illness, and I'd like to give him an opportunity to explain his involvement. However, he may have to check with my co-founders to see his time limit. Let's welcome Dr. Stratford, please.
Thank you very much. I'm just a local physician here, and actually I'm here to learn as you are. I'm really grateful to see how many of you are here, and I'm really humbled myself to introduce Dr. Goldstein to you. He's a prolific author. He's resided in California for the last 25 years, married, has a son, Jordan. He received MD from the University of Pittsburgh. He's done much of a psychiatric residency. He's done a family practice residency. Been certified by the American Board of Family Practice, and again recertified. He works a great deal in California. He has taught psychopharmacology or the chemistry of the brain for some 10 years at UC Irvine. Has been a prolific lecturer. Has been involved in excess of 48 seminars and conference presentations. Has at least 28 publications to his credit. I have tried some of his recommended treatments, and I've been very pleased to tell you that how successful and easy they've been, and I hope that we can learn a great deal about them today, myself as well. Really, he's a primary researcher in a real novel dysregulation theory, which is an entirely different paradigm or different viewpoint from many conventional medical experts. He's had the opportunity to publish at least 3 books. You might see that in some of the handouts. Chronic Fatigue Syndrome, The Struggle for Health, Could Your Doctor Be Wrong, and The Limbic Hypothesis, which is a very detailed book in itself. The senior medical editor for Medical Neurobiology of Somatic Disorders, Regulation of Neuroimmunoendocrine Networks in Health and Illness, and he's written a chapter in a book which will be out in the next week entitled Fibromyalgia Syndrome, a pain modulation disorder related to altered limbic function. He's a very energetic man who has an enormous amount of detail, and I look forward to all of us learning this afternoon together. I'd like to introduce to you Dr. Jay Goldstein.
everybody. Very happy to be here. And I'd like to explain to you today why you feel the way that you do and what you can do about it. I've been working on this for about 10 years, and I believe that I've kind of figured it out. This is a very treatable illness, at least in the patients that I see who come from all over the world. I would say that about half of the new patients that I see feel dramatically improved the first day that they're there. And maybe 25% more feel that way the second day. In order to understand this illness and numerous related illnesses, it's necessary to think of health and illness in a way that doctors and patients have not been used to thinking about it until now. Not that they're used to thinking about it now, but at least there's a way to do it. And that has to do with the way that the brain regulates itself and regulates the rest of the body. Doctors are used to thinking of the various illnesses as being what are called organ specific. That is, if your stomach hurts, then the problem is in your stomach. If your muscles hurt, then the problem is in your muscles. If your throat hurts, then the problem is in your throat. You should take antibiotics. Well, as you know, that way of looking at things, although it's been very successful for many medical disorders, does not help you. And so if you don't remember anything else that I say today, why don't you take away with you that chronic fatigue syndrome and fibromyalgia and related disorders are disorders of how the brain regulates itself and regulates the rest of your body. They're disorders of information processing. The brain does not process information from the inside of your body, from the outside world, and from its own structure the right way. And so you feel and experience things that you shouldn't, that would be inappropriate to the situation that you're in. Your muscles hurt when there's no reason for them to. That's because your brain interprets touch sensation as being painful. You feel weak when you walk across the room. You get easily exhausted. And that's because your brain interprets the most mild physical activity as being like running a marathon. All of the symptoms can be explained in this way. Many of the ways that your body may work, like in your immune system and your hormone system, might be dysregulated. In a very basic sense, this is because your brain is acting on faulty information. The information that has been processed turns out wrong. And so your brain responses are inappropriate. And so you feel that your body doesn't work right. In a nutshell, this is how chronic fatigue syndrome, fibromyalgia, and related disorders work. And in a way, this is like holistic medicine. But it's not like the kind of holistic medicine that you're used to hearing about, which is done mainly with nutritional products and homeopathy, things like that. This is viewing the body as being an integrated whole. All of the parts of the body communicate with each other in a network, usually by chemicals that talk to different parts of the body, but sometimes by direct nerve impulses. And it would be possible for the network to be deranged anywhere and have the whole thing not work right. But no matter where it's deranged, the conductor of the orchestra is the brain. And it's mainly the parts of the brain that have greatly expanded during human evolution that distinguish us from lower life forms. We'll be talking a little bit about that later. Until very recently, we've not understood well what these parts of the brain do, even though they wouldn't be there for no reason. And in a sense, the illnesses that we'll be talking about today are uniquely human illnesses. There are no animal models for them, and even if the animals had chronic fatigue syndrome, it would be hard for them to tell us. So why don't we get started with the slides? Anyway, these are what I consider to be the infamous criteria for chronic fatigue syndrome that have been promulgated by the Centers for Disease Control in 1988 by a committee of about 20 doctors. And they're just a conglomeration of symptoms that seem to, that have no coherence, and there's no indication at all about why these should be connected in any way. But I think that this illness and variations of it are the most common things that people see their primary care doctors for. There's a new definition that should be out soon, and I've been to some of the meetings in which the criteria for it were discussed, and I wouldn't expect it will be much better. It'll be a little less restrictive, so that more people will be able to be diagnosed with it. But the conferences were very much like how many angels could dance on the head of a pin, and really didn't get into why the people were sick. People at the National Institutes of Health and the Center for Disease Control maintain that they do not know why they feel the way that they do, and my interactions with them would confirm that, in that they're relatively clueless. This case definition has been used against the patients by the insurance companies, saying that you have to conform to the case definition in order to be diagnosed with chronic fatigue syndrome and to receive disability benefits for it. When really this was made to do research, and it was accepted that doctors in clinical practice would not necessarily have to find patients that conform to all of these criteria.
Dr. Goldstein, can you read that to us?
Oh. Well, it's rather long. You have to be fatigued for 6 months, and your level of activity has to be less than 50% of normal. That's one of the, what they call the major criteria. They don't define how you're supposed to tell what's 50% of normal or not. And you can't have ever been fatigued like this before. If you take careful histories from the patients, they will admit to having had 1 or 2 days or a week maybe of being like this 5 or 6 years ago, and if that were true, then they couldn't have chronic fatigue syndrome. Other conditions have to be ruled out, which led many doctors to do $1 million workups, often with equipment that they own, so that you could be sure that you didn't have cancer of your pancreas that was making you feel this way, or things like that. And then there are a bunch of what are called minor criteria, and you need to have 8 of these if you don't have any of the physical criteria, which almost nobody does. And that includes low-grade fever, sore throat, painful lymph nodes, muscle weakness, muscle pain, feeling very fatigued the day after you exercise, headache, joint pains, neuropsychological problems, sleep disturbances, and having this begin in a matter of hours or days. You don't have to have all of these to have what I would chronic fatigue syndrome, although I don't like this name even. This is just one of a large group of disorders that are caused by your brain not regulating properly. Okay, well, these are just a few of the things that people have when they have chronic fatigue syndrome. And almost all of these can be treated as disorders in and of themselves, depending upon what doctor you go to and what the focus of interest is of that particular doctor. Up until quite recently, when I saw patients, for example, that had fibromyalgia, it was the rule that their rheumatologists had never asked them anything else besides about their pain. And so, whereas almost all of them would have problems with their memory, their rheumatologists had never asked them about that. Really, one of the problems with this illness was that at the beginning, we thought that it was an infectious disease because we thought that there were epidemics and that they might be caused by the Epstein-Barr virus. And so the infectious disease people, the immunologists, the virologists got mainly involved. And they didn't and don't still know very much about how the brain works. There have been almost no neuroscientists involved in studying these illnesses until very, very recently. And so I think that at least for the first 7 or 8 years that were spent studying this illness by most people, that about 90% of what was done was a waste of time. And there's going to be a lot more money available for grants to study chronic fatigue syndrome in the next year or two, and the sharks are already circling in the water. It will be mainly the old boy network that will get the money. And so I would expect to see more of the same, just in a more expensive version. Could we, I named this list of illnesses, and there are more than these, but these are all that I could put on one slide. Neurosomatic. Read some of them, yes. Irritable bowel syndrome, panic disorder, amnestic disorder, that means you can't remember things well, allergic rhinitis, blurred vision, twitchy muscles, myasthenia, which is weak muscles, interstitial cystitis, which is where your bladder hurts a lot, various kinds of sleep disorders, headache, bruxism, which means grinding your teeth, irritable bladder, which means that you have to urinate a lot, alopecia, meaning that you lose your hair, thermoregulatory dysfunction, meaning that you feel too hot or too cold all the time, and that you perspire a lot, and that you can't stand to be outside in the heat, and you can't stand to be outside in the cold either. Painful lymph nodes, shortness of breath, even at rest or when you exert yourself, could include their chest pain of unknown etiology, chemical sensitivity, where very low levels of certain odors make you feel very sick. That's called cacosmia. Endometriosis, late luteal phase dysphoric disorder, also called PMS, heart palpitations, and various disorders of cardiac rhythm, not being able to stand bright lights or loud noises, vertigo, Raynaud phenomenon, meaning that the tips of your fingers turn white or blue, particularly when they're cold, painful menstrual periods, and at least 30 other ones that I didn't put on the slide. And all of these, I think, are primarily caused by your brain not regulating you right. Can we have that slide, please? A while back, I decided that all of the symptoms that people experience could be caused by dysregulation of a neural network in the brain called the limbic system, LIMBIC, limbic system. The limbic system was described first in the 1930s when it was thought to be the basis of emotion. But since then, we've learned a lot more things that it regulates. And I can read a piece since Hannah seen it in the back. And this would include all of the functions that are dysregulated in you folks. That would be fatigue, pain, sleep, weight. It's very common for me to see a woman who gets sick and gains 50 pounds in 6 weeks. Appetite, sex drive, respiration, temperature, which is usually low, blood pressure, which is usually low, memory, which is virtually always impaired, particularly short-term memory, attention, concept formation, mood, vigilance, the immune system. Usually the brain suppresses the activity of the immune system. We'll see that later. And so I think that the immune activation that we see in people with chronic fatigue syndrome is due to dysregulation of the brain's suppression of immune system function. It also regulates the endocrine system and helps to modulate the nervous system and the rest of the body, what's called the autonomic nervous system. Next slide, please. Well, about 1987, I developed the idea that this might be due to a virus that was working in a way that we didn't think that viruses were supposed to work. We thought that viruses were supposed to kill cells or change their structure, or that they were supposed to excite the immune system so that viruses would be destroyed. But if there were a virus involved in people who have chronic fatigue syndrome, it just changed the function of the cell without changing the structure. There was no evidence of cells being killed and very little evidence of cells having the structure altered. And so this is a new way to think about viral illnesses. These sorts of viruses, if they did exist, would have to be ones that would somehow evade the immune response. So that when you would look at a cell that had a virus in it, you might be able to see the viral particles, but you wouldn't be able to see any of the immune cells around the cell as you would when there would be an inflammation. Next slide, please. There can be more than one virus in a cell too. We see this with AIDS. And the genetic material of the viruses can make the cell make chemicals that would be different from what it usually makes. And the two viruses also, two or more viruses, could also interact with the way that each other work. This is a process called transactivation, which is seen perhaps in AIDS, where you could have a cell latently infected with HIV, and then when you get a second virus in there, it can activate the HIV. Next slide. Okay. And so if there is a virus, and we've been looking for one for a long time, we may have found one, and we may have found a way to kill it. All of the cells would not necessarily have to be infected with the virus, but just a few cells would have to be, and then they could make chemicals that would have effects on non-infected bystander cells, so that it could kill them, or it could do other things to the function of those cells. This is how mononucleosis works. You get sick because the infected cells make more immune transmitter chemicals called cytokines. This is probably how AIDS works, although I don't know why this has penetrated into the H lines. Because in AIDS, you just have about 1 out of 100 cells that are infected with HIV, yet lots and lots of cells die. And there has to be some kind of toxic product that's made by the infected cells to kill the other cells. Next slide. And in about 1988, Dr. Cheney and I came up with the Agent X hypothesis, where there's some predisposing kind of factor that makes a person get chronic fatigue syndrome. Back then, we thought that it was a latent virus. Now, I think that it's a genetic predisposition. And the genetic predisposition can be strong, weak, or anywhere in between. Next slide. And so we did genetic testing a few years ago, and our results were confirmed by a second group, in which this particular genetic locus was seen in a much higher rate than you would see it in the normal population. And what we noticed too was that there was this, that people had panic disorder in their families if they didn't have it themselves. There are some resemblances between panic disorder and chronic fatigue syndrome.
What is panic disorder?
Panic disorder means that you can be feeling fine, and then you have a sudden experience where you feel very anxious, your heart goes fast, you feel faint, you might feel numb, and you have a feeling of impending doom. You may feel like you're going to faint. And this can last anywhere from a few minutes to a few hours. It's like a really, really bad anxiety attack. It usually is not related to any external stimuli. Some people have thought that these are sort of related to seizures, and there's a borderline between what's a seizure and what's a panic attack, because people that have seizures that come from a part of the brain called the temporal lobe can feel very panicky without losing consciousness. We'll get into all of how this works later. Next slide, please. So if there is a virus, and really I don't think that there is in the usual sense that we understand viral illnesses. I think that if there is a virus that you have to be genetically predisposed to react to the virus in a certain way that will make a whole chain of events happen that will make you sick. And as we'll talk about more later, it's not just a genetic predisposition, but what happens to you in very early life has a role in this too. When you're an infant and when you're a child, your brain is still growing and it's still maturing, it's still developing. And if you're exposed to more stress than your developing nervous system can deal with, it's not going to develop properly. It won't regulate itself right. It will not process sensory information properly. It may process it as being, say, more threatening than it should be. For example, preterm babies that have been in neonatal intensive care units for 1 or 2 months were compared with a matched control group of term babies many years later. And it was found that the premature babies had a much higher incidence of somatic complaints, body complaints, than did the control group. If you take newborn rats away from their mother for just 15-minute periods, now and then, they develop changes in how a regulatory area that we're going to look at later called the hippocampus works. And they stay there for the entire life of the rat. They don't go away. Even if you just do this maybe 4 or 5 times in the first 3 days or so of the life of the rat. Children that are raised in abusive families are, well, it's catchword now to say dysfunctional families, but where they're raised in an environment where there's more stress than they can tolerate, have the same kind of thing happen. And so they're a lot more likely in later life to have some sort of illness like this, and I think that it has to do with the way that their brain develops and the way that it processes information. So those would be some of the predisposing factors. I have lots of patients who say that they've been sick for their entire lives and they can't remember a time that they weren't sick. I have several families in which 4 or 5 people have chronic fatigue syndrome. But the amount of time that you've had it and the severity of it doesn't have any effect on your response to treatment. So I've had people who have been sick for 40 years get better in half an hour. And the way that I look at it now is just a matter of pushing the right chemical button. I don't have all of the buttons to push yet, but I have a lot of them. The only way that we'll be able to cure this, that is, make you better without taking medications, is for you to somehow do it yourself in a way that we don't understand. For there to be a virus or some other infectious agent that would be causing this that we can kill, or for there to be some sort of gene therapy where we can change the way that your DNA makes chemicals. That, I don't believe that that will happen in my lifetime, because it's too complicated in this kind of disorder. So when you get a viral infection, the virus is taken in by a cell of the immune system, or it can go into a brain cell. And then, next slide. I think that we've already talked about this, about what latent viruses can do in people with chronic disease. So let's move to the next slide. It gets digested and then it gets displayed to other cells. All of this is under genetic regulation. So that's why you're all exposed to the Epstein-Barr virus. You all have antibodies to it, and yet only 5% of you get mononucleosis, because that has to do with the way that your immune system handles the virus. Next slide. And the way that it makes immune transmitter kinds of chemicals, the kinds that it makes and the amounts that it makes is also under genetic regulation. So everybody's different. And this is going from the immune system here, but it's certainly true in the nervous system as well, and that's why not all of you will respond to the same treatment. Next slide. The most current idea among the immunologists working in chronic fatigue syndrome now is that it's a primary disorder of immune activation, and that's what this slide shows. That there could be a persistent viral infection that we haven't found, or that a virus gets into the immune system and leaves, but results in an immune system which, for some reason, does not turn itself off. And they believe that the immune system products make the person sick. This was an idea that I developed in about 1988 and have since abandoned. With many of the immunologists and lots of other people that work in this field, the only tool that you have is a hammer. Everything looks like a nail. And so it's an immune dysregulation, and there's a lot of money in that for the babies. Next slide. But as I said before, a much more productive way to look at it would be as a network disorder. where all of the different parts of the body regulate each other. Next slide. Back and forth. And so you can theoretically have the problem start here, or here, or here, and have everything else in the network be affected by it. But the mechanism for the causation of virtually all of the symptoms comes from the brain. And this has been an extremely difficult idea for me to get across to my colleagues, virtually none of whom are trained in neuroscience. And then there is a kind of tunnel vision that exists in our leading academic institutions, where if they don't know it, it can't possibly be. Next slide, please. And so in about 1988, we began to study brain function, and we did it in lots of different ways. This is a PET scan. PET stands for positron emission tomography, and it measures the brain metabolism of glucose, which is the main energy-producing sugar in the body. The idea being that if your brain is working right, then the different parts of it should use as much glucose as it can, and if it's not, then you're using less. And here, this is normal down here. This is low in the brain, this is high in the brain. This is the front, this is the back, this is the right, this is the left. You can see how in the patient, what we're trying to see over here, there's a lot more purple in these regions particularly than there would be here, where there's mainly yellow and red. And we fairly routinely see this when we do PET scans, which we don't do anymore because they're very expensive. But we did a whole bunch of them. Next slide. Purple means that there's low metabolic activity. There's a low utilization of the glucose in that region. Well, one of the things that became rapidly obvious to me was that a region of the brain called the dorsolateral prefrontal cortex, right here. This is the front of the brain, this is the back. This is the top, this is the bottom. This is one of those areas that have grown a lot in human beings as compared to, say, rhesus monkeys. That when we looked at the PET scans, most of the areas to which the dorsolateral prefrontal cortex sent nerves were not working right. And so it became important to see what the dorsolateral prefrontal cortex did. Back in 1988, we didn't know too much about that. And I'll be talking more and more about this. Let me just give you a brief introduction to it. It's unique among the areas of the brain in that it can regulate its own neurotransmitter input. That is, it can tell other parts of the brain that make neurotransmitters how much neurotransmitter it wants. These are things like dopamine, serotonin, norepinephrine, acetylcholine, basic neurotransmitter chemicals that help the brain work. And so, depending on how it judges the importance or the saliency of a human stimulus situation, it can regulate its own function. This is the only area of the brain that can do that. And the way that it does that is that it sends nerves that secrete a different neurotransmitter called glutamate to virtually all of the areas of the brain to tell it how to do things. And it, again, regulates its glutamate secretion on how it decides what the saliency of the stimulus information is. How important it is, what it means, how it compares to what the person has experienced and learned earlier in life, what the cultural attitudes of the person are, and what his genetic temperament is, how he was born to have his brain be programmed. And what it does is that it regulates the flow of information in and out of processing centers in various parts of the brain. It does a lot more than that, and I don't want to make this too complicated. But it regulates information flow in the brain. And in virtually all of the patients that we study, there's something wrong with the dorsolateral prefrontal cortex. Next slide. The main tool that we've used thus far is called the brain SPECT scan. That's a way to measure brain blood flow. And we use two different chemicals to do this. This one uses radioactive xenon, which is a harmless gas. And this is low in the brain, this is in the middle of the brain, this is high, this is the front, this is the back, this is the right, this is the left. The normal brain should have uniform blood flow through all of the areas of it. And so this is a relatively normal picture. Next slide. And this is a person with chronic fatigue syndrome. Obviously, you can see that this does not look like the last picture that you saw. People who have chronic fatigue syndrome usually feel worse after exercise. So what we did was that we had people exercise and then we did this again. Next slide. Well, I did this at least 100 times until I was really convinced that this happens. And this is what happens, I say, about 95% of the time. In the normal person, either there is no change in brain blood flow or it goes up. And so we feel that this is pretty diagnostic, and I just don't look anymore because I already know what's going to show. And so I thought, well, what would happen if I gave somebody a drug that would improve brain blood flow? And so I did. Next slide. Yes. This is the first patient that I gave a drug called Nimontop to. It was in 1989 when it had just come out the day before. And after he had taken it for a while, he felt better. He felt better and his blood flow got better. And so I thought, well, this is easy. All that we have to do is increase brain blood flow and the patients will feel better. Well, that's completely wrong, as you'll see later. Next slide. It was very early, obvious to me because I did tend to talk to my patients that they had problems remembering things. And so we studied memory in patients with chronic fatigue syndrome. This was published in the well-known medical journal Newsweek, where we found mainly that people had a problem making new memories. It's a process called encoding. This has been published also in the psychiatric literature. And that's a process that occurs in the hippocampus and is regulated by the dorsolateral prefrontal cortex. We did electrical tests of of a lot of the same people that are called, that are auditory evoked responses, where they get a beep in their ear, and then we follow the electrical activity of the brain, through the brain, to see how the sound is processed. And what we saw in 100% of the patients was that they had what's called a decreased amplitude of the N100 wave. This is a wave that is thought to be generated by the dorsolateral prefrontal cortex and the hippocampus. And so it's looking like we're getting somewhere. Next slide. When we were doing the exercise testing, we noticed that some of the patients had marked irregularities in the amount of air that they breathed in and out when they were doing maximal exercise. When you're running as fast as you can, you should be breathing as much air in and out as you can too. But lots of our patients didn't do that. Next slide. Well, what you would see normally is that as your energy expenditure increases, that the amount of air that you breathe in and out, which is called the tidal volume, goes up until you can't breathe in and out anymore. This is in a normal person. Next slide. So what we saw about half the time was something like this, where the tidal volume was almost random in people who were exercising. Automatic respiration is regulated by the limbic system. And so this was more evidence for there being a limbic dysregulation. Next slide. This is the most graphic example that we have of a patient. Next slide. And so this was what we saw in people that we have who exercise. This is rather significant. When your muscles make energy, they do it by converting glucose to a compound called acetyl-CoA. And that's done with oxygen. When the muscles can't get enough oxygen, they do it without oxygen in a much less efficient process that's called anaerobic metabolism. The way that the muscles do this is regulated by a nucleus in the hypothalamus of the brain called the ventromedial hypothalamic nucleus, which is regulated by glutamate. Once again, that's the main chemical that the dorsolateral prefrontal cortex makes. And it sends projections to just about everywhere in the brain. Now, this process of the way that your muscles metabolize during exercise begins even before you start to to exercise. Your brain gets your muscles ready to do this. And so if your dorsolateral prefrontal cortex is not regulating your limbic system right, which does not regulate your hypothalamus right, then you can have a low anaerobic threshold, which we see lots of times, and could account for muscle insufficiency, and I think is related to why some rheumatologists mistakenly feel that this is a muscle problem, primary muscle problem, but they don't know about this. Next slide. Yeah, perhaps we could move that down a little bit. Well, this part here in the orange, thank you, is the limbic system. Forms a ring around the middle of the brain. This is the hippocampus here. This is a related structure called the amygdala, and the dorsolateral prefrontal cortex is here. Now I don't want to go through a lot of neuroanatomy because it's very complicated, but say that someone touches you. The information goes into your spinal cord, goes up the brainstem into a kind of like a switchboard called the thalamus, and then goes up here where it's sensed as touch. For what this means, and to learn to remember the touch if it's important to remember, then the information gets transmitted to the dorsolateral prefrontal cortex and to the hippocampus. If for some reason you need to remember this experience for a long time, the trace of memory gets repeated hundreds of times while you sleep in the hippocampus, and then is distributed out to many areas in the rest of the brain. So there are nuclei in the thalamus here, which as I just said is the main switchboard of the brain that determine whether information will be transmitted to the cortex where it will be sensed. Pain and touch go into the nuclei of the thalamus by two different pathways. And if this is working right, touch will be blocked out, and just pain will be transmitted up to the cortex. If these nuclei in here are not working right, if they do not properly inhibit touch sensation, then touch will be transmitted to the cortex as pain. And something like this is why you have fibromyalgia. The concept of it is not very difficult to grasp, although no one seems to have grasped it yet. This is not Einstein's theory of relativity here. You just have to know how the brain works. Okay. Why don't we go to the next slide? The areas in pink are the ones that have been expanded the most in human beings. They're called heteromodal areas. That's where sensory information is processed and compared to what you learned previously and to what your attitudes are. Next slide. As I said, you have long-term memory made in this region of the brain called the hippocampus with a process called long-term potentiation. This has been very well studied in what's called cognitive neuroscience. There's a lot that's known about long-term potentiation and how new memories are made. Not too much is understood yet about how new memories get stored, but a lot is known about how new memories get made in the field of cognitive neuroscience. And what I'm saying is that virtually all sensory input goes through these same kind of processes and it is subject to the same rules, more or less, as what happens in the making of new memories by long-term potentiation. Next slide. This is just to show that the anatomy that we're dealing with here is very complicated. Next slide. Could you focus a little bit again, please? Thank you. One of the things that we know about chronic fatigue syndrome is that people's brains don't make enough of what's called CRH, also known as corticotropin-releasing hormone. It's mainly known for making the adrenal glands make more cortisol because it stimulates the pituitary gland to make what's called ACTH, which makes the adrenal glands make more cortisol, but it does other things too. It makes your brain make more norepinephrine, which is like adrenaline. And then it sends pathways up to the dorsolateral prefrontal cortex and helps to regulate the way that works. And so this is one more reason why your dorsolateral prefrontal cortex might not be working right, is that it doesn't have enough CRH in it. Corticotropin-releasing hormone regulates lots of other brain chemicals and is regulated by lots of other Next slide. And it regulates hormones that are involved in reproduction, growth of thyroid function, and the immune system. And so, as I said before, if you have too little of it, then the way that your body works is going to be screwed up. Next slide. I didn't think that the corticotropin releasing hormone in and of itself, with all of the things that we knew that it did, could account for all of the abnormalities that we saw in people that had chronic fatigue syndrome. And so I had the idea, which I still don't know whether it's right or wrong, that an immune transmitter chemical, called interleukin-1 beta, is not made right in the brain. That's this. Interleukin-1 beta stimulates the secretion of the corticotropin releasing hormone. And this is stimulated by lots of things, more than just this. And if this is working right, then your immune system will be suppressed, and you wouldn't have things perhaps like nasal allergy, eczema, asthma, all of which are more common in people with chronic fatigue syndrome. Next slide. And so if this was blocked, then you could have an immune system activation, because we measured this in the spinal fluid and it's normal. And so the only way that this perhaps could be involved would be if the pathway between here and here were blocked. Next slide. To review a little bit again, corticotropin releasing hormone regulates the sympathetic nervous system and the immune system, and they all regulate each other too. And so if this is too low, then you could have your sympathetic nervous system not work right, a condition called dysautonomia, and you could have immune activation again. And that's what we see. Next slide. Now, when we do brain specs, we see mainly that there's decreased blood flow in the dorsolateral prefrontal cortex, and to an extent in this region of the anterior lobe where the hippocampus is. People who have major depression are more apt to have abnormalities in this part of the prefrontal cortex. And if they have them here, it's on the left side of the brain. People with chronic fatigue syndrome tend to have them on the right side of the brain. People with chronic fatigue syndrome who are depressed look just like people who have chronic fatigue syndrome. People who have fibromyalgia look just like people who have chronic fatigue syndrome. So we can distinguish usually chronic fatigue syndrome from depression by doing brain effects, and we have the lead article in the new Journal of the Chronic Fatigue Syndromes about this. That'll be up in November. Next slide. And so there's been a circuit that's been described in monkeys between the dorsolateral. Oh, does it work now? Thank you. Prefrontal cortex and the hippocampus down here that we had suspected from all of the other evidence that I presented to you during the first half of this talk. And I don't think this works right. As I said, for a long time, we thought that this was a disorder that was caused by the immune system making too many cytokines, immune transmitter chemicals that made the brain not work right. But when we measure them in the brain, they're all pretty normal. The way that chemicals work on cells is by attaching to receptors, sort of like a key fits into a lock, and then making things happen inside the cell. There are lots and lots of receptors. There's a lot more than this. And probably they're all involved to a greater or a lesser extent in people with chronic fatigue syndrome. Since I had the idea that maybe we weren't making enough corticotropin releasing hormone because the actions of interleukin 1 beta in the brain were being blocked, I looked at the various chemicals that could do this. And you don't really have to remember this. But one of them was this endothelin, and we'll be talking about that more later. It's the most powerful vasoconstrictor in the body, and it does a lot of other things. So when as I said, when I saw that there was all of this vasoconstriction in the brains of people, I thought, what could I do to expand their arteries? And so I tried to give them NO, which stands for nitric oxide, which is a vasodilator as well as a neurotransmitter, and it's how nitroglycerin works. Nitroglycerin turns into nitric oxide, and that's how it expands arteries. Perhaps coincidentally, things that block the action of interleukin 1 beta also block making nitroglycerin in your brain. This is a complicated slide, but it's an important one, and I'd like to spend some time on it. Could you move that a little bit? Thank you. This is called a synapse. It's where two nerves talk to each other. This is called the presynaptic neuron. This is called the postsynaptic neuron, and this space here is called the synapse. And usually chemicals go from this nerve to this nerve and make it do things. In this case, the chemical is glutamate. This is what's involved with making a new memory. Nerves like this, and there might be 100 of them around here, secrete glutamate. And the glutamate hits receptors for glutamate on this nerve. And then calcium goes into this nerve and does things. One of the things that it does if you want to enhance the memory trace is that it makes nitric oxide, which is a gas. That diffuses out into here and goes into all of the presynaptic neurons that are firing. Ones that are not affected. They're not permeable to the nitric oxide, and it will increase the secretion of the glutamate by presynaptic neurons, so that it will strengthen this microcircuit. Is this clear to everybody? Yes or no? Okay. So, if you don't make enough of the glutamate, then this input is not going to be as strong. And if you don't make enough nitric oxide to stimulate more of the input, then you won't form a memory very well either. And I think that this is the basis of the information and processing abnormality that you will have. And so the way to treat it from the standpoint of molecular neurobiology would be to increase this and this. It turns out that it's rather hard to directly increase the glutamate. Glutamate doesn't get into the brain, and the ways that we have of trying to increase it aren't very good. I could talk about this after the lecture if you're interested, but we can certainly get nitric oxide into the brain, and the simplest and And the cheapest way to do it is by giving very low doses of nitroglycerin, because you need much less nitric oxide to act as a retrograde neurotransmitter than you do to dilate arteries that are all filled with calcium and fat. And many of my patients feel a lot better in general after they take nitroglycerin. Not all. None of my treatments work for everybody. And I think that one reason for that is that this is a very finely regulated, minutely regulated process. And when you just give a person nitric oxide, you're just kind of dumping it into the brain. And that just might not work in a delicate situation like this. It could be too much, it could be in the wrong place. It's a very gross way to intervene in a very fine mechanism, but still better than nothing. And it's rational. One of the things that lots of doctors and patients don't know yet is that the brain can change the way that it works very much. That it's not hardwired once you become an adult. That nerve cells are always changing their connections, their degree of sensitivity, their receptors, the amount of transmitters that they secrete, the way that they work inside, depending on what the environmental situations are and what kinds of chemicals they're exposed to. And that's why you can feel real bad one day and you can feel real good another day because of neuroplasticity. This is why for women who get PMS is that after you ovulate, just in the normal course of events, your nerve cells change the connections in certain regions of the brain. And if your dorsolateral prefrontal cortex is not regulating information transfer here properly, when your hormonal milieu changes, you're going to feel weird when you shouldn't. And I think that that's how PMS works. And that's an example of neuroplasticity, just like making a memory is an example of neuroplasticity. But 3 or 4 years ago, we looked at what happened to things that were regulated by interleukin 1 beta and lipoprotein releasing hormone after people exercise. There's a lot of data on exercise physiology, and since people were trying to think of this so poorly with exercise, we wanted to see if we could tell what were some of the parameters of this poor performance. We saw that they really didn't raise their cortisol very much. It should like double after you exercise. Once again, I thought that there might be a block here in the releasing hormone. So there would be other reasons that this could happen besides this, but this is still, in my mind, is a leading candidate. And so it could be something like this, too. And we'll be having a quiz on this after. But what we saw was that all of the things that were supposed to happen, these are the ones that we measured after exercise, didn't. Not only did cortisol not go up, but even temperature didn't rise. When you exercise, you should raise your temperature 2 or 3 degrees, but we had people where their temperature went down. And it was quite remarkable. And this is just one more example of the kind of dysregulation that I was talking about. And this has been confirmed by a group in Holland. To show you in graphic form how what I've been talking about works, these are the various inputs. And here's where they're processed. And then here is the output. And so what I'm saying is mainly happening is that the way that the inputs are summed is being dysregulated by the dorsolateral prefrontal cortex, and then the way that the output is regulated also is being dysregulated, but that there does not necessarily have to be anything wrong with the way that the information would be processed in here once it gets in. This is a model of what's called a neural network. These are inputs, neurons with different weights of the input. This is where it's processed, and then these are the response neurons that work on the output. And so, from what I'm saying, the problem would be here and here. So, what do I do when I see a new patient? This is all in the handout that you should have already received, and I have 2 more on here. 2 more on your handouts that are not in here. But I begin with a certain kind of eye drop that works within seconds, if it works. Then I use nitroglycerin. Then I use nimodipine, which we already talked about. And then I just try one thing after another, because I know how long each of these drugs takes to work. And if it's not worked by a certain period of time, it's not going to do anything, and then I go on to the next one. And these are all pretty safe drugs. I've never had a really serious adverse reaction since I've been doing this. People might not feel good after one, but that usually goes away in hour 2 or 3. One of the most interesting things that I use are a certain kind of eye drop that's like a strong version of Clear Eyes, which you would use when your eyes itch or when they're red. It's about 8 times as strong as what you can buy in the store, and it's been used mainly by allergists for people whose eyes itch for about 30 or 40 years. And so we know all about whatever adverse reactions there could be, which there are hardly any. And so I've been trying to modulate brain activity any way that I could. And so one way is by trying to stimulate nerve endings on the eyeball that go through what's called the trigeminal nerve. That's the nerve that conveys sensory information from the face to the brain. And it goes back here into this little tract, which then helps to regulate how the brain works. Sort of like this. It goes here into what's called the reticular formation, which helps to set the level of arousal and lots of other activities in the brain, as well as up here into the thalamus, which we've already talked about. And it helps to regulate the way that it, what we call gates information, lets it in and out. But first I'd like to show you that you can have an abnormal brain spec that you can feel bad from things other than doing exercise. This is a young man who had to drop out of Cambridge because he suddenly was unable to do arithmetic anymore. But he was a marathon runner. When he began to do arithmetic, he became very fatigued and he had to go to sleep. And so this is his baseline SPEC scan. This is one after maximal exercise, which is not too much different. And then this is one after we had to do calculation. So there's lots of things that can make your brain work wrong, and it sort of depends on you. So we began to see what happens when you use the eye drops. Why do they work? Because I've had people be sick for 10 years and put in the eye drops and feel normal in about 5 seconds. Get out of wheelchairs and stuff like it would be if I were a painkiller. And so this is one of these patients. This is her baseline SPECT scan, which really doesn't look too bad. And then she puts the eye drop in her left eye, and you can see that she has a decrease in her brain perfusion even though she feels better. She puts it in her right eye, she feels much better, and she has a further decrease in her brain perfusion. Well, it seemed rather paradoxical to me that she should feel better, but her brain level should be less. So I didn't know whether this was a fluke, and so I did it again with somebody else. This is her at the baseline, not puts a drop in one eye, feels much better, puts it in the second eye, feels normal, but there's almost a wipeout here. And so I began to think, well, maybe brain blood flow doesn't necessarily have to directly correlate with how the person feels. So then we did some more people with nitroglycerin, and this is more like what we consistently see. This is before, this is after. Nitroglycerin is a vasodilator. That's how it works when you have heart disease. It expands the arteries in your heart so that your heart muscle will get more blood to it. But in the patients that we test, the reverse happens, even though they feel better. Nimodipine is used mainly for people that have brain hemorrhages where they get spasm of the arteries in their brain, which you would want to reverse when you would give a medication so that the brain would give enough blood. But this is what we see pre and post nimodipine. Again, we see that clinical improvement is associated with decreased brain blood flow, at least acutely, at least in the, well, we do these 1 hour apart. So here, he feels a lot better, but he has a lot less brain blood flow. And so what could be doing this? Well, there are lots of chemicals that expand the arteries in your brain, but there aren't very many that constrict them. And the top 3 candidates are these. And the only one of them that dissociates brain blood flow from brain metabolism is this one. That is, it can decrease your brain blood flow while it increases brain metabolism. Endothelin. This is an 11 amino acid neuropeptide that was discovered in 1988. Once again, it's the most powerful vasoconstrictor in the body, and it releases glutamate and nitric oxide. So it looks like this would be a good candidate for what might all of these different medications, because I haven't shown you all of the medications that we tested, but they all do the same thing. When a person feels better, at least right away. We've not tested this very much after a year or two, because each of these things costs about $2,000. And I'm kind of tapped out right now. I'm not sure what causes endothelin to be increased. Actually, we're measuring endothelin right now in the spinal fluid of about 30 patients that have fibromyalgia, and we should have results at the end of the month. Interestingly enough, people with major depression have spinal fluid endothelin levels that are half that of normal. And that's the only disorder so far in which endothelin levels have been found to be low in the spinal fluid. They've been found to be high in lots of things. But Dr. Bennett has been working on growth hormone, which works in the body by stimulating the liver to make a thing called insulin-like growth factor beta. It would be possible that this could be involved, but I think that would take too long. Platelet activating factor is released from platelets as well as from the lining of the arteries, and it acts as a retrograde neurotransmitter like nitric oxide does. And so right now this would be my top candidate for what's making this film go up. One of the drugs that I use, called Fibromyalgia, methadone, it increases growth hormone in the brain by a lot. And if you're depressed, it increases it in the brain by a lot more than if you're not. And even though chronic fatigue syndrome is not depression, there are relationships between the two of them.